Hello, everyone. Thank you so much for joining. We'll get started in just a minute. So glad you're able to join us. We've been looking forward to this for quite some time. Thank you for being here today. My name is Savannah Gray. I'm the Clinical Program Manager with CMQCC, and I am absolutely thrilled to get to introduce you guys to our webinar today, titled Let's Build Something Together, Insights from the Community Birth Partnership Initiative, which is a project of CMQCC. We have three excellent facilitators today: Krista Walzak, who is our CMQCC clinical lead, Holly Smith, who is our CBPI project lead, and Dr. Melissa Rosenstein, who is the CBPI physician lead. Thank you all. Just for some quick introductions and housekeeping, everyone is going to be muted and our chat function is disabled. But if you have questions during the webinar, our Q&A box is open and our facilitators are ready to answer any questions that you have. They'll be writing out answers, so just wait for those to pop up because we will see them as they come. If you have any questions after the webinar, Krista is more than welcome to answer those, and her email is here below, or you can reach us at info@cmqcc.org. The webinar will be recorded and slides will be available on the CMQCC website on the Community Birth Partnership Initiative page. And you're welcome to use any of these slides for education with your teams. If you modify or add any information in the slides, just substitute your organization or institutional logo with the CMQCC and you can remove that for us. And without further ado, I will hand this off to our team. Thank you, Krista.
So the objectives today are to understand the goals and insights from the Community Birth Partnership Initiative, the CBPI pilot project that we've been working on for a couple of years now, to identify best practices for hospitals, community midwives, and EMS to strengthen collaboration and improve transfers across birth settings. And ultimately, we do hope that you get to apply some of these concepts from the toolkit and the CBPI pilot to begin or advanced transfer improvement locally. Next slide. So, the Community Birth Partnership Initiative, what is it all about? Well, the mission of CBPI is to really improve those health outcomes during pregnancy and birth by increasing the quality and whole person safety of hospital transfer processes when a transfer is needed for community birth. And that applies to emergent and non-emergent transfers. To enhance integration between perinatal care systems that have traditionally worked in isolation from each other in California, focusing on our shared responsibility, that is of hospitals, community midwives, and EMS to improve outcomes. And that QR code will take you to our Community Birth Partnership Initiative page where you can find all kinds of resources. Next slide. So why focus on community birth? When we're considering improvement in the birth space, all birth care settings must be considered. We can't leave anything out in isolation. This is a quote from a recent article that really explains and hammers away how important that this is as part of the birth space. Excluding planned community births, those intended to take place either at home or in a freestanding birth center, from quality collaboratives provides an incomplete picture of birth in the United States. It also limits the opportunities to promote greater integration of maternity care across all settings and providers, expand care options for childbearing families, and generate much needed quality improvement across the full spectrum of care. So really, it's our responsibility as a quality care collaborative in California to include community birth. Next slide. So the integration of birth care providers and systems really increases our chance of success of fulfilling our overall mission is to create a safer birth space for all Californian birthing people. A more integrated system is safer and it can address some other opportunities that we've been experiencing throughout California and the nation, and other things that we really include in all of our projects as highlights. CMQCC is well known for hospital-based quality improvement, and we've developed a lot of resources to improve care delivery in California. Things like equitable care are interwoven in all of our work, which includes respectful care that honors patient choice and shared decision-making, which is also part of this project. Data is at the center of quality improvement, and currently we have incomplete community birth data that can further inform this work. CMQCC can leverage their experience developing measures and creating analysis tools that include this missing data to give us that whole picture. Hospital closures impact access to care and have challenged us to consider all care options and the improvement of systems that support these options. Part of this work highlighted the critical role that EMS plays in obstetric care, especially in rural settings. It was very eye-opening. We went to our first EMS conference in the spring of last year and really exposed us to all the opportunities for collaboration with EMS, not only for care during transfer, but management of obstetric emergencies in the prenatal and postpartum periods, which is something we've been called on to do as a PQC and many other projects. Next slide. Nationally, there's a call for transfer improvement with particular emphasis on perinatal quality collaboratives like CMQCC to perform this work. ACOG endorses hospitals and community midwives to work together to improve care and transfer. So this isn't something that is new or coming out of nowhere. It has been reinforced by our professional societies. Next slide. A recent article, a call to action in the Journal of Midwifery and Women's Health, gives us a roadmap with specific state-level tasks. These tasks include at the state level, community midwife representation and perinatal quality collaboratives, creating community birth to hospital transfer improvement programs, creating a mechanism for client and provider feedback on transfers, and establishing QI programs in state midwifery organizations. QI programs in state midwifery organizations is largely already happening, so it's right now our responsibility to put the other pieces together for the state to integrate the systems. Next slide. Nationally, this work is getting increased attention. This recent article highlights a part of the project that we want to make very clear and will emphasize throughout the webinar, that there's a shared responsibility for transfer improvement. It's not just up to hospitals or just up to EMS or just up to community midwives. We have to work together to improve this process. I'll read very briefly from this article, and you can see it in the orange text. With each contraction, Maria Ibarra's plan to deliver her daughter in her Ohio living room seemed less likely. The baby's heart rate was slowing, her midwife said. They needed to go to the hospital right away. Ibarra's midwife, Megan Noland, called labor and delivery at the closest hospital but had trouble reaching anyone. When a charge nurse finally answered, Noland identified herself as a midwife and asked if the hospital would be able to admit Ibarra, whose baby had a concerning heartbeat. But she was taken aback by the nurse's response, "We just won't take walk-ins." Obviously, by EMTALA standards, this person could not be turned away, but even having such a conversation wastes precious time and infers that the patient may receive judgmental or disrespectful care upon transfer. This could encourage the midwife to choose a different facility that may be further away when minutes count. This project holds all of us equally responsible for giving the best possible care to each person, whether they intended to give birth in the hospital or give birth in the community setting. Just want to call out that the title of this article, When Home Births Go Wrong, is not great. It doesn't really depict what we're trying to achieve here. And we talk a lot about that in this initiative. How the words we use makes a lot of difference. It makes a lot of difference between provider communication, and it makes a lot of difference in respectful treatment of our patients. With that, I'll hand it over to Holly Smith, who's a nurse midwife and the project lead for the Community Birth Partnership Initiative.
Thanks so much, Krista. Hi, everybody. I'm just super excited to see how many folks are on this call. Many of you I know, but a good portion of you I don't. And that's just a wonderful insight into how interested folks are in this kind of work and what we're doing for the Community Birth Partnership. All right, so I'm going to do an overview of both the Community Birth Partnership and the Transfer Toolkit that we've been working on. I'll take you through it step by step. What we hope has happened with this toolkit is that it will be a really easy to use toolkit that you can simply grab and go and get what you need pretty immediately to start up such a thing in your region or hospital. So next slide, please. Krista already spoke about the mission of the CBPI. Oops, sorry, I'm going to go back to my notes here. Krista already noted the mission of the CBPI, which is to, one, improve health outcomes, of course, and to enhance integration between perinatal care systems that have traditionally worked in isolation from each other. But to accomplish this, we are specifically working to improve relationships and sustain collaboration, co-design policies for hospital transfer by community midwives and hospital providers, ensure safe, coordinated, respectful transfer of care every single time, improve understanding of community birth and reducing stigma around home birth and birth in freestanding birth centers, and ultimately improving the patient experience of transfer and eventually utilizing transfer data to improve whole person safety and improve those uh, the guidelines that each group is working on. Next slide. So we started in Yolo and Sacramento and Riverside counties, and now are in, and we're still there, working with them in the sustainability phase. And we're now in San Bernardino, San Diego, and Mendocino County as well. And San Diego and Mendocino actually are San Bernardino and Mendocino are quite important to us given the rural component there, which remains top of mind right now as rural folks are really experiencing the maternity ward closure situation. Next slide. We aren't the first to do this, and most of you likely know that. This started in Washington State with Smooth Transitions years ago now as really the flagship program that initiated this turn. Oregon followed suit with inside of the Oregon Perinatal Collaborative with their transfer toolkit. Also in Colorado, there's the Colorado Safe Transfers Coalition. Alaska and Utah have similar programs, and now California has finally entered. Next slide. So the Community Birth Transfer Resource Kit was also something that was published, I'm going to say, maybe last year, a year ago. It might be a little bit longer than that. The work of those other states that I mentioned really led to the development of this transfer resource kit. And it's honestly the best place to start for more in-depth information. Like I said, we are providing for you very much a short grab and go kit. But if you need more information, more resources, this is really the place to go, is to the AIM Community Birth Transfer Resource Kit. Next slide. So here's what we did. We brought these 6 teams together and started with education and moved on from there to their actual meetings of their Perinatal Transfer Improvement Committee, and I'll get into that in a little bit. But the basic components of the Community Birth Partnership Initiative are virtual learning opportunities, virtual and in-person collaborative work sessions between community midwives, EMS as well, and hospital staff to co-design policies for transfer, and also virtual and in-person simulations of transfer to practice and improve processes. Moving into this year, we are really excited to be working with the folks up in Washington at Smooth Transitions to implement surveys of patient experiences of transfer, as well as provider experiences of transfer in community midwives and EMS participants. That information is so important because at the end of the year or at certain intervals in time, these groups can look at that information and see very specifically what clients, patients, and providers are saying about how the transfer went and how those guidelines that they created together are actually working. And then that's a feedback loop to informing changes to those guidelines that are truly patient-centered and coming from the patients themselves. Next slide. And this is a placeholder. That's why you'll see if you go to the CMQCC website that these surveys will be available to our teams pretty soon. Next slide. We modeled our program after the successful projects that I spoke about. Smooth Transitions gave us so much useful information and guidance, and were consultants to us throughout this process. So these steps seem pretty straightforward, and I'll go through them in a second, but we wanted to also give you the tools to readily accomplish these steps, to show you what it looks like in real time. So you will see that the toolkit is set up specifically for that. So the project steps are as follows. First, recruiting champions from hospital and NICU, meaning L&D and NICU, EMS, community midwives, Then there is a period of education and pre-meeting readiness. Then everyone gets thrown together in a virtual room to begin meeting as the Perinatal Transfer Improvement Committee. And part of that is having this core triad of the Perinatal Transfer Improvement Committee, which you'll see in a moment, which is EMS, community midwives, and hospital. Then they begin co-designing guidelines for maternal newborn transfer for an intended community birth. And then after that, there is hopefully continued collaboration around data collection, benchmarking what kinds of transfers they're having and for what reasons and how they went, simulations as well, and further co-learning together. At the end of that time, hopefully they begin to meet at least quarterly. And again, utilizing those experience surveys and debriefs and just their own discussions about how these transfers went to inform those guideline improvements. Next slide. So here's how the toolkit is set up for you then. I'm going to go through these step by step. Each of these steps are really only a few pages in length. I think the total toolkit length is about 28 pages. But the point here is to create an immediately actionable guide to improve transfers. Next slide. So this is the question that comes up every single time when we talk to either facilities or midwives who want to begin this in their region. It's just like, where do we begin? Hospitals say, you know, who are the community midwives in my region? Who even transfers here? I know a name of someone maybe, but that's all I can remember. And midwives similarly don't know who to talk to sometimes in the hospital. Like who is the right person to get to? Will they be even interested in this project? Next slide. So doing the research is really key, and we've given you some really easy tools to use in the toolkit, including an online search with keywords, regulatory listings, how to go through the regulatory listings at the Medical Board of California to pull up a list of midwives, licensed midwives in your region. And then also state professional associations and the links to their websites and the Find a Midwife tools. And also talk to CNMs at your hospital. If there are CNMs who are privileged at your facility, they just might have midwife friends and know where to lead you to do this work with licensed midwives and CNMs in the community. We provide you with some links to our state professional organizations, which are the California Association of Licensed Midwives, or CALM, and the California Nurse Midwives Association, and encourage you to reach out to them to figure out who might be in your region. And of course, I'm speaking directly to the hospital side and EMS side at this moment. And then also there are national organizations you can be in touch with or may have or do have Find a Midwife tools on their sites. That includes the National Association of Certified Professional Midwives and the American College of Nurse Midwives. Next slide. And so the next thing then is to assemble the team. Here, this graphic shows the core triad for starting a community birth transfer improvement committee. This does not mean that other folks are not important, because of course, these committees should also include doulas, patients who have experienced transfer. So when we say core, that doesn't mean more important or in control. Rather, these are at least the three necessary systems that need to come together and be in the program to make it successful. Next slide. All right, so here's where the magic happens. And I know this is going to sound really simple, but we made it very simple on purpose because sometimes we think that creating these committees is some kind of magical rocket science thing that happens. But in fact, the steps are really easy. Can you go ahead and click there, Savannah? Oh, you did. Great. So, oh no, go back. Apologies. So here's how it goes. Go to your computer. Pull up your email, write an email, a nice one, hopefully, and invite these people to be part of this work. And this goes for the hospital side or the community birth side or for EMS. And by the way, the toolkit is is tracked that way, in that it shows if you are coming from the hospital, here's what you do. If you're coming from the community birth site, here's what you do. And essentially invite them to be part of this work. You can even say, if you want to, name drop that CMQCC is really promoting this work for safer care. And then just acknowledge that you don't have all the answers on how to do this, but that getting the right people on board will move you closer to success. It's truly that simple for assembling the team. Next slide. Also key is to not assume that there isn't already a similar thing happening. In fact, there is work for community birth transfer improvement already happening across the state. In LA County, there's a Black Birth Equity Initiative working on this, Birth Bridges in San Francisco, there's the Sonoma Birth Collective. I just spoke with a physician today, in fact, who is working with a community midwife in their region on this work for years now. So truly leverage the local work that's already being done, if it's being done. And of course, you would only know that by being in touch with midwives and doing that research part that I just spoke about, and leverage that work to make bigger and better progress. Next slide. Also really key as you're assembling this team is if you are doing this, regardless of what part of the core triad you're coming from, you're probably the key liaison for that part of the triad. It's also important then to identify the other leads, to identify who's the lead hospital champion, who's the lead midwife liaison, who's the lead EMS champion. And they act as liaisons for the purposes of meeting facilitation and also spreading new information to their respective professional communities. Next slide. And so here we have some resources for you in the toolkit. The readiness section of the AIM Community Birth Transfer Resource Kit is really phenomenal. It goes through this partnership that needs to happen in much more detail and how to do it. So definitely no need for us to reinvent the wheel, go straight there for more information. But we've also provided for you a template outreach email and a template roster as you're assembling your team to keep track of who's interested and involved. Trying to make this just as easy as possible. Next slide. So pre-meeting education, and by meeting, we're talking about that very first perinatal transfer improvement committee meeting where everybody's in the same virtual room together. So don't skip this step, super important. What we've learned, and even myself through this process, is we shouldn't underestimate that we don't know what we don't know, and really coming up to speed on what is happening around us outside of our professional circles will lay the foundation for good communication when you're finally in that meeting with folks that you've never had to kind of have a collegial relationship with in this way. Next slide. So the pre-meeting education for hospital is a little bit bigger than it is for everybody else, and that's because we have learned that there is more for the hospital side to learn about what's happening in the community birth space than the community birth has to learn about the hospital space. So we've kind of mapped this out to create some self-directed reading for you. All of this stuff actually is on the CMQCC, well, not all of it. A good portion is on the CMQCC website under the Community Birth Partnership, but links are provided in the toolkit to everything else that is not listed there for these specific things. So understanding the CBPI initiative, there is a PDF there with frequently asked questions about transfer, why it happens, how often it happens, how midwives decide to transfer a client. There's info there about the midwifery model and philosophy of care and how that differs from the medical model, because that's oftentimes where some of the deeper conversations happen when there are just perhaps misunderstandings or just differences in how care is provided that ultimately lead to a safe outcome, but people do these things differently based on your education and training. We have a document there about midwives being essential maternity care providers, and more. I want to bring your attention to a very cool continuing education, which is called Transfer Tools for Midwives, EMS, and Hospital Providers, which is created by Hive CE. That link is in the toolkit. There's a 4-hour CE, also a 1-hour version, I believe, that is specifically directed at the core triad, including EMS. Start there, actually, if you're new to this space. I've also included a YouTube video of Kindred Space LA. That is a Black-owned birth center in Los Angeles, South LA. And that video gives just such a wonderful explanation of what community birth actually looks like and what is provided through that process. And then before the first transfer improvement meeting with community midwives and EMS, the lead hospital champion, so whoever has been designated in that role, should meet with the other hospital champions to just answer questions, ensure you're all on the same page. Also, perhaps show the CMQCC CBPI slide deck ahead of time to review the goals of the initiative and what you're there to do. And all of those things will be super helpful as you enter that first meeting with everyone else. Next slide. Additionally, for EMS and community midwives, there's some pre-learning as well listed here, very similar to what was on the other slide, with the exception that EMS also has their own slide deck that's specific to the work that they do, entering a home for a 911 call, how to interact and engage with the midwife there. So there's information specific to each part of that triad in the toolkit. Next slide. And this slide just shows that once again. Next slide. So now I'm just going to go through a little bit about what is in the education and also what's in that the pre-meeting slide deck, I guess, or webinar, I was going to say, but slide deck that we do at the hospital side. We talk about who are community midwives. Let's just start from the very beginning. And since I have you all's attention, for those of you unfamiliar with the community birth space, I'll just go through these very briefly. So community midwives, that's a term that we use rather than out of hospital. And so you'll hear community birth, which is also referring to birth in settings such as the home or a freestanding birth center. So community midwives specialize in the care of essentially healthy, which is a way of saying low risk, birthing people and newborns in the out-of-hospital setting. So I've used out-of-hospital to explain there, but by combining the midwifery model of care, which is a patient-centered, community-oriented, low intervention, and emphasizes continuity of the human presence during labor, using that model of care with medical techniques to safeguard normal birth. Next slide. Our educational material on the website and in the toolkit includes information such as this that reviews what kinds of midwives provide care in California, including licensed midwives and certified nurse midwives, as well as their typical sites of care. In California, starting at the bottom, moving up, a few CNMs provide home birth, but mostly licensed midwives are in the home birth space. Moving to freestanding birth centers, some CNMs provide care at freestanding birth centers, but more licensed midwives do so. And then in the hospital setting, at least in California, only CNMs are providing care in the hospital setting. Next slide. So California actually has the highest number of midwife-attended births in the nation, which of course makes sense because we also have the most births. Correct, Krista? Or maybe I think our birth rate has gone down a little bit, but I'm still pretty sure that we have the highest birth rate of other states. But to be clear, that does not mean we have the highest proportion of community births. I believe that's Washington or New Mexico. So there's about 55,000 total midwife-attended births in California. This information is from a couple of years ago. Our birth rate has gone down a little bit. So somewhere between 4,000 and 5,000 of those births happen in the community setting, meaning about 2% of California births happen in the community setting. And that's similar to what happens nationwide. Next slide. So we're talking about transfer improvements. I think it's important to give some information around community birth transfers and transports. Transfer from home birth or a birth center to the hospital happens in about 11% of community births in the intrapartum or immediate postpartum period. If you were, however, to just look at nulliparous patients, so just a first birth, the rate is higher. It's somewhere in a third of clients who are having their first baby will transfer. But if you look at the whole, it's about 11% overall. Interestingly, the most common reasons overall for transfer is not for emergencies. Clients come by personal car or by their midwife for pain relief and labor augmentation when labor progress is slow. Emergency transfers happen in about 2% of cases, and the most common reasons for emergency transfer are severe postpartum hemorrhage and fetal bradycardia. And also newborn transfer should be in there as well. I think this was information from just intrapartum, but newborn transfers occur as well. And actually, before I go to the next slide, just to give some context to then how many transfers actually occur in California across all 58 counties. If you have 4,000 community births, there's about roughly 100 emergency transfers a year, perhaps around 500 non-emergent transfers. So when we're talking about emergencies specifically, it truly is a rare event, which is why we have to practice for it, right? And we'll get into that. Next slide. So the typical community midwife patient is essentially healthy. That means no significant pre-pregnancy or pregnancy conditions that are likely to adversely affect the birthing person, fetus or newborn. The client has one fetus in the head down position, full term at the time of labor, and risk assessment is ongoing from the very first prenatal visit throughout labor and postpartum. Next slide. All right. And here's just a little bit of more information about what the pre-meeting education materials look like on the website. Obviously, this webinar is not to talk only about what community birth and midwifery care looks like in California. We have other webinars on our site that go over that, but mostly I wanted you all to just get a picture of what's included in the toolkit. Next slide. And once again, referring you back to the AIM toolkit if you feel like you need more information. Next slide. All right, so now here's the good stuff. We're doing the first meeting as the Perinatal Transfer Improvement Committee. And honestly, the first meeting is really easy and it's meant to be easy. And I guess easy is relative, right? Everyone comes into it feeling a bit nervous and awkward. But it's easy in the sense that it solely focuses on introductions and building rapport. In fact, in our meetings, we take a good first half hour just to get to know everybody in the group. We go around, we might do an icebreaker, we might not, we might just talk about our backgrounds and what brings us into this project. We then frame the initiative and review the goals once again. We also review meeting communication rules, so conversation rules, and we talk about those conversation rules at the first 3 to 4 meetings, just to review the fact that we speak respectfully to each other. We understand that sometimes we'll say things that might offend the other side of the table if we're looking at it as sides of the table, but that we don't mean to, that we really assume positive intent from our professional colleagues and try to move beyond those feelings that we're having. So we reviewed such things in the conversation ground rules. We also review the meeting cadence. We answer any questions and concerns back and forth, meaning hospital answers community birth questions, community birth folks answer questions for the hospital folks. And then this is also a time where participants may want to review what they want to focus on as a priority for this work. Really important, the designated leads should, just got a note from Krista to speed up a bit, so I'm going to do that. The designated leads coordinate meetings, document these discussions, and follow up on any outstanding tasks. But also really important that they meet ahead of time as of before the full first committee meets, so that they kind of work out who's going to speak on what issue and how that agenda is going to flow. Next slide. And here's just a little, again, first meeting resources. We even include the agenda for the first meeting. This is modeled off of what Smooth Transitions has done, a follow-up email to everyone, the conversation ground rules, but there in that orange square, the template transfer guidelines adapted from Smooth Transitions is really like the paper you have in hand for the next meeting when you start to work on those guidelines. All right, next slide. So then after that, the follow-up meeting should be scheduled monthly for the next 3 to 4 months. And this cadence really provides time to discuss and finalize intrapartum and newborn guidelines. Usually some groups are slower than others, some are faster than others. And then after that period, the team transitions into quarterly meetings in order to maintain that open communication and, as you said previously, sustain those goals, benchmark your information, review what you've learned throughout these transfers and so forth. Next slide. Just want to be really clear, though, that transfer improvement meetings are not protected case reviews. There is a way in California to make these meetings protected case reviews, but as it stands between community midwives who are not privileged in the hospital facility or credentialed in the hospital facility, this is not a protected case review. So the committee, when talking about transfers, should really identify strengths and gaps using insights from the transfer experience surveys and hypothetical scenarios. And then if specific case requires intense review, it should be referred through the usual case review channels. Next slide. Oh, I just want to note, actually, sorry, go back, that we also have here in the resources for step 5, things like debriefing. We have a few debriefing models. The one from Utah is amazing, the 3-question debrief form, because it's just really easy. We've provided our standardized debrief form as well. And then we have various transfer templates here, an SBAR for community midwives, an SBAR script for receiving facilities, best practice guidelines, again, from the and tips for welcoming a transfer from the Oregon Community Birth Transfer Partnership. So a lot of really core things for subsequent meetings to learn about. Next slide. So I'm going to pass this along to Melissa Rosenstein, because this is where in these subsequent meetings that we have our first in-person meeting. And that is really, really super important. And Melissa's going to talk about that.
Hi, everybody. Glad to be here. I'm Melissa Rosenstein. I'm a MFM obstetrician. I practice clinically at UCSF, where I work on labor and delivery and have been involved in many transfers as part of my job. And so I want to just say this project has been a lot of fun. And one of the big pieces is this in-person meeting, right? Is really fun. So we really get together. We've been on Zoom. We're getting to know each other. And then we come together in person to do some real work. And, you know, we've had the education. And when we come together, what we really figure out is that respectful maternity care is really the foundation of what all of us do when we come to work every day. And that shared commitment is kind of the through line for the work that we're doing and makes it all go really smoothly. And that's what I'm going to share today. So Holly shared a bunch of resources, and this ACOG resource of collaboration and practice implementing team-based care is really helpful. And those of us who work in the hospital are really accustomed to team-based care. We have nurses and midwives and OBs and pediatricians and anesthesiologists, right? And so the idea of this partnership initiative is to really expand that view into partners that are outside the hospital, including our community birthing partners and our EMS folks, which again are sort of not who the labor and delivery team might always think of as our partners. And then the other piece is remembering that who is really the center of the partnership, and that's really the patient. And so these guiding principles for team-based care, while not necessarily discussing community partnerships, is really very helpful. And so remembering that says ACOG, we didn't make this up, that patients and families are central to and actively engaged as members of the healthcare team. And that, again, is fundamental to the work that we do. And so one of the ways that we kind of get to know each other better, a little bit beyond the surface of where we live and our hobbies, is doing this values framing exercise. And it really is a way to step back and realize how all of us who work in this sphere bring our own experiences and perspectives into patient care. And so we do this in what's called the values talk. And I'm going to give you a little brief introduction to what that is in the next slide. And so this idea is that we take a moment to say, what are our beliefs, priorities, and principles that guide what matter to us and influence the choices that we make, right? We all have these. And we didn't get them from nowhere, right? They came because of all of these things that are on this list, right? Our beliefs and values are created by, are informed by, and are protected by all of these things: our family, our experiences, our history, good and bad, our cultures, our traditions, the social norms and expectations, where we work, what our coworkers think, any religion or faith traditions that we have, how we were educated, and our mentors and elders and other respected folks in our community. And these values, I invite you to take a moment and think about this, and see how this resonates with you, and realize this is part of who we are. And we do want to sort of hold on to it and protect it, because when there's a threat to our values, it can be really difficult. And so next slide. And I think for providers, in medical providers, this really does come to the fore when we have these discussions, right? So as an OB provider, right, part of my values and beliefs about where birth should happen are really are exposed not just because of where I was educated and what I was taught in my medical school and residency and all of that, but also, experience with prior transfers. And this goes both ways with both of our, education and the way that our community birth providers and what the education that they have gotten and their experiences, and the way that we both look back at our prior birth transfer experiences and think, wow, a doctor might think, wow, I remember that transfer that was transferred so late and the person had a complication, and I really wish that, she'd been transferred earlier or had had her birth in the hospital to begin with. And there may be community birth partnership, our community birth partners who might think, I remember that transfer. She was transferred. She was treated terribly. They didn't listen to her. She ended up with a C-section that she didn't need and was in the ICU. I wish we had never transferred her, right? And we bring these thoughts and our feelings and these values into the work that we're doing, and our ideas of risk and what's the best thing, and all of these things come into it, and we need to acknowledge it and make sure that we realize that this is in this space that we're working in and needs to be addressed. And that's what we get to do together. Next. And so, again, just to say, it's not just the providers, it's not just the nurses and the doctors and the midwives and the EMS providers, and the pediatricians who have values and beliefs, right? It's our patients, right? That's who their value system is helping them decide where they think the best place to have a baby is, and where their best case scenario is going to be regarding their birth. And so I think, understanding, we all think about safety and, what's the safest place. And I think for a lot of people who work in a hospital, we think that the hospital is the safest place. And for a lot of people who have had other experiences, they think that the home is the safest place away from the hospital and all of the intervention. And so just remembering that when people make decisions about where to have a baby, granted, not everybody spends a lot of time thinking about it. Sometimes it just is what's available to them. But many people, particularly folks who choose community birth, have many values and beliefs that are deep-seated and are informed by all of their experiences and education and elders and mentors, that are helping them to arrive at their decision-making in terms of if folks choose community birth, for the increased autonomy, for increased connection with their prenatal care provider, which can be hard in the current medical model, and being in their own space of this family-centered environment, in addition to some other things that are on that list, contrasted with people who, like, on purpose are choosing a hospital birth for the extra interventions and for the access to all these medical opportunities that are not available. And so recognizing that everybody is coming to the table with values and beliefs that are impacting their decisions, I think can be really helpful as we try to work together. And so when we recognize our attitudes and our values and beliefs, what's super important is that we recognize that these values and beliefs not only impact our attitudes, but then they can impact our actions and our words. And, here on the slide, you can see that there's two different ways to address somebody who might be showing up at a hospital when it was unplanned, right? And our values and our beliefs and our attitudes might lead us to say something like, "We're so glad you're here with us, and I'm so sorry things didn't work out how you planned." Or it could lead us to say something like, "Why would you want a home birth? You're going to be so much more comfortable here," right? And what we're trying to do in this space is recognize that these words and our actions are underpinned by these values and beliefs. But when we recognize that, that's when we can start to make changes and center, like we talked about, that respectful, patient-centered care. Next. And so, our core values are so important. They're not easily changed. And the point is that we can recognize that we might feel threatened, right? Sometimes I think doctors and nurses who spend a lot of time working in the hospital feel threatened by somebody who is choosing against us. Like, what, you're choosing to not have me participate in your care. That makes me feel kind of bad. And we have to recognize that. We don't have to change our core beliefs. We just have to recognize how we feel when they might be threatened. Next. Because changing our beliefs are really hard, and we don't really have to. Although I will say, one of my favorite moments from the pilot group was working with one of the hospital-based providers at the very end of our working together for over a year, who looked at me and said, "When this started, I never understood why anybody would have a home birth, but now, after getting to know them, I can totally understand why that would happen. It's still not might be my choice, but I can understand where my patients are coming from in a way that I didn't before." And so that's where we're headed towards, not necessarily changing our own beliefs of where the best place to have a baby is, but to be able to open up and understand what else is going on. And next slide. Because this is why we go through this mini therapy session, right? If we can understand our self-awareness, if we have better self-awareness, if we can understand why we make our decisions, then we can get closer to that empathy and compassion to provide that quality, respectful care to our patients when they arrive, knowing that they might come to us requesting different things and hoping for different things than what they're ending up with. And I think, and we're going to go through some actual tools, right? So the toolkit just came out today. It's really fun. It has a lot of stuff going on. And I think once we've gotten through this idea of, okay, we understand why we might behave less than appropriately during a transfer, how do we get to that respectful care? Sharing clear information, respecting hospital processes, listening to patients, right? So these are just some examples of ways that we encourage everybody in the room to practice recognizing what their biases might be, and then concrete tools to provide respectful care to patients during the transfer. Next. And here's some more tools. So it's in the toolkit. We said pages 12 and 13, lots of different concrete ways that we can make sure that our patients feel respected, and that our colleagues who are coming to us for collaboration, or if we're on the community-based midwife service side of it, the folks who are coming to accept our transfer, that we can have that respect, not just for our patients, but for our colleagues as well, and the EMS providers who are helping to do the transport and stabilization. And so this is just bringing it back to this team-based care, which, again, remembering that the way that a team is going to work together is with this shared vision. And that we're saying, which I think is already true for most of us, that respectful care is our shared vision. And when we do that, we become more efficient because we just talk about the truth and we don't have to talk about our feelings as much in front of the other teams. And we have more collaborative communication, and the birthing patient experiences greater dignity and support with better outcomes. All right, Holly.
Thanks so much. It was a great representation of that first in-person visit. So we've talked about doing the research, assembling the team, pre-meeting education, and then also meeting virtually, and finally for that first in-person visit or first in-person meeting. And now on to simulations. Why do a simulation? I will say, hands down, the simulation event, and this is also what participants told us, was the most important and just gave the most benefit to this initiative was doing the simulation together, because it's not only a way to practice what is a low frequency event, right? That makes us all nervous when it does happen because we don't see it very often. But it's also a really significant team building activity. So we're combining those things at once. It enhances respectful client-centered care, team building and trust, improves response times, creates a culture of learning, and identifies system gaps. I can't tell you how much we identified with each team that we did these simulations with, in terms of where improvements need to be made. One of the big ones being that sometimes patients get stuck in the ED when they should be going immediately to the labor floor, and that wastes precious time. That was just one of many things that these hospitals and community midwives and EMS identified that they could all work on together. We utilized Step Up Together, which is a program of primary maternity care. They were awesome, and they have built out a program that it's in the toolkit that anybody can utilize on their own with what they call drill kits that sets up the drill for you. You can choose what you're drilling for, and, whether that be an issue with the newborn or postpartum hemorrhage or whatever it might be, and it gives you everything you need to do a high fidelity drill from the home or a freestanding birth center, utilizing EMS, getting in the rig and going all the way to the hospital and just doing that from beginning to end. It's really something. So definitely recommend that. Next slide. Just a few resources there that's in the toolkit. And then finally, how do you sustain the work? After you get through this first year, you've done all of this work together. What do we do to continue to learn new things, improve our guidelines, and so forth? This checklist here reflects what are the structure measures. Now, for those who are not familiar with CMQCC's data center or might be in the non-hospital side, structure measures are measures that CMQCC provides to hospitals to as essentially a checklist, a way to know if they are meeting their goals as a way to get from A to B, right? So sustaining the work includes quarterly or semi-annual meetings of the Perinatal Transfer Improvement Committee, transfer experience surveys with a clear plan for how patients and providers will be notified of the changes that need to be made. A written sustainability plan. That sustainability plan is in the toolkit and can be utilized. Even having new employee orientation materials and so forth. So everything is laid out here to sustain the work. We're now going to play two videos from a couple of our team members from the UC Davis team. Melanie is from UC Davis, is a nurse, and will be presenting on the team building experience they did when they visited the California Birth Center. And then Rachel will be telling about another team building experience as a community birth midwife giving a grand rounds presentation for hospital staff. And you can go ahead, Savannah, and play that. These are just the resources for.
So I had an opportunity to give a presentation for Grand Rounds at UC Davis Medical Center for their OB department. It was attended by about 150 staff and students. And I shared what midwifery care looks like from start to finish, client selection, what our prenatal care looks like, what our intrapartum or birth care looks like, how we care for folks postpartum, all of those pieces that I think that most providers, they had no idea. They had no idea how many visits we saw folks in the postpartum period. I think how long we get to spend with them, typically about an hour, was super surprising. And that we pay attention to a number of factors in terms of on our decision making and client selection. And so I think that those were probably the most surprising things. And I think as a whole, community birth providers and hospital providers, we all acknowledge what is super high risk, and we all acknowledge and probably agree on super low risk. It's all those gray areas in between about the differences between midwifery care and the medical model of care. And I think that with more conversation, it really helps us to understand each other and how we may come to different places in decision making, even based upon the same circumstances, but how we do it, how we go about doing it, the tools that we have in the midwifery world to help reduce preeclampsia, for example, or address anemia may be different, but we are all desiring to address those things. And I think because we all want to make sure that the families that we serve are well cared for. And I think that it also hopefully conveyed to the medical providers that we do want to have a relationship. We do want to, as community providers, be able to access those tools, that care when our families need it. And sometimes none of us are sure where the folks will ultimately need to birth, but we want to have those relationships because we understand what the limitations of our care, and we want to continue those conversations, and we want to be able to continue those conversations in lower stress settings outside.
When I visited their site. So I got to go to the freestanding birth center, which was just so eye-opening as a high-risk delivery nurse who works at a level 1 trauma center, and how it's like offers similar things to us, and how calming it was when I just walked in the room. I remember that. It was just so lovely. And I understood why people want to deliver there. And I think I always see all the bad stuff. We see a lot of bad or things that go south and don't end up being bad because we have all the resources there to do it. And seeing how they keep resources available to them if they have an outcome that's not what they're expecting, but also how the patients have that freedom of having an experience that they want to have in having it in the tub or having it on just a regular bed that's really nice. It doesn't have bars in inappropriate spots, or their family can all be there and they're not limited on number of people there. And so I thought that was really a lovely thing. And honestly, just how much better it has solidified our relationship with our community midwives, and how we now have a workflow in place if they have patients that need additional services. So we have a workflow now that they can contact us to get things in place for additional testing or additional services. So that's nice.
So hopefully that gave you just a little quick excerpt about why these simulations and the co-learning experiences are so important. Just one quick thing, I know we're at time. This next year, we will be working much more closely with our EMS colleagues to determine the best ways that we can co-create some best practices for EMS, as well as how to go about in a system that's very decentralized but highly protocolized for EMS to help them understand some key things about community birth and improving protocols and getting on the same page around transfer. And so far, every EMS person we have spoken with in this initiative is super excited and willing to learn, and that just is really encouraging, I think. So back to you, Savannah.
Thanks, Holly. And thank you so much, everyone, for joining us. Thank you for hanging on a minute or two after. We hope you've learned a lot. We hope that you enjoyed the presentations. Wanted to share really quickly before we say goodbye that our MICPOP Perinatal Potpourri Conference will be taking place April 16th and 17th. The team has been working really hard to make it an excellent event to share community resources, to share education opportunities, to really be rooted in community and transforming care together. So you can scan this QR code or sign up and register at cmqcc.org. Again, thank you so much for attending. There will be a webinar survey that will populate in your browser or will come to you via email after this webinar. And again, thank you so much for coming, and we will see you all next time. Thank you so much.